So neuroblastoma is a childhood cancer that arises from the sympathetic nervous system. And what we've learned over decades of research is that there is a small proportion of patients, around 1 to 2%, that have what we call familial neuroblastoma. That's really a positive family history for the disease. But recently, through genome-wide association studies, or GWAS studies, we've identified a number of susceptibility loci that correlate with the development of the disease. So now we're thinking that neuroblastoma susceptibility is more of a spectrum. So with that in mind, we wanted to better define the genomic landscape and susceptibility of neuroblastoma. So through the Gabriella Miller Kids First Research Consortium, we were able to run a study of 556 neuroblastoma patients. And the unique thing about this cohort is not only is it large within a single pediatric cancer subtype, but we also have paired parental data and paired tumor data, which allows us to understand if these rare germline variants that we're seeing in the patient and could possibly be related to the disease is inherited, and also if it shows up in the tumor and shows evidence of driving the tumorigenic process. So it's really the aim of the study is to better understand what is happening at the genomic level and understand its influence on the development of neuroblastoma. So we had a rather complex algorithm that was developed by my collaborator, Zalman Waxman, who is a bioinformatician. And what we did was took a numerous amount of genomic sequencing. We had germline data, whole genome germline data on parents, whole genome germline data on patients, and then we had tumor whole exome and RNA sequencing. And through the identification in this algorithm, we were able to use that data to, one, identify pathogenic or likely pathogenic germline variants in the patient. We were then able to do a familial linkage analysis. We looked at the parents to see if they were inherited, and then downstream effects in the tumor, where we're able to look at loss of heterozygosity or different degrees of allelic imbalance that could show us that this rare variant played a role in tumor development. So with this large cohort, we also had a large amount of data. And so we had whole genome germline sequencing on the parents and on the patients. And we had whole exome DNA and RNA sequencing on the tumor. So through a very precise and complicated algorithm that was built by my collaborator, Dr. Zalman Waxman, who is a bioinformatician, we were able to first look at the patients and identify if there were pathogenic or likely pathogenic germline variants in cancer predisposition genes. And we had a list of 197 cancer predisposition genes that we sought out these germline variants in. From there, we were able to perform linkage analysis using, or familial linkage analysis using the parental data to see if these variants were inherited. And then turning to the tumor, we were able to see if there was evidence of the role of the variants in the tumor development. And we were looking at things like loss of heterozygosity and allelic imbalance to help suggest that the variants had a role in tumor development. So to date, we've had 3 key findings. The first was that 16% of our cohort had a germline pathogenic or likely pathogenic mutation in a cancer predisposition gene. And this was in the realm of what we had expected, given recent data from other large genomic sequencing efforts. The second key finding was that the vast majority of these germline variants were inherited, about 94%. And within that 94%, there was an equal proportion between maternal and paternal inheritance. And that was a really unsuspected finding for us, that the vast majority of these variants were inherited. And then the third significant finding to date is that patients that harbor these pathogenic or likely pathogenic germline variants fared worse than other patients without these germline variants in terms of event-free survival and overall survival in a statistically significant way. So this data is still new, and we're still trying to better understand what it means. But there is a really broad possible implication. So for one, how we counsel families. So one of the most common questions we get when we're counseling a family at a new diagnosis is how this will affect the siblings. Will their siblings be at risk as well? And historically, we thought that this wasn't the case. But as we're learning more and more about inherited germline variants and cancer predisposition genes, that may change, and our counseling and who we put on a surveillance path may change. The second is really in regards to the treatment plan. So if we're identifying that patients who have these germline variants do worse, perhaps they need escalation in the treatment plan or a different type of treatment plan. And this is all very early, but things that we're thinking about and needs to be further discussed within the neuroblastoma community. And lastly is how we surveillance patients after they come off treatment. If we get them into a remission and we put them on a surveillance schedule that monitors for recurrence, if these patients are at higher risk for recurrence, we need to follow them more closely. Again, this is all very early data, and we need to think about it and discuss it more deeply within the neuroblastoma community, but it's something that comes to mind when we see results like this. So one of the things that we're currently doing is investigating the difference between the phenotype and the genotype and phenotype between patients and their parents. As I mentioned before, 94% of these variants were inherited, but only 1 to 2% have what we classify as familial neuroblastoma. Again, that's a family history of disease. So our current efforts is looking at better understanding this discrepancy, why so many of these variants are inherited, but the families really don't have this multi-generational disease prevalence. And so what we're thinking is that there's really some modifying factors that tip the scale in the direction of tumor development. And we're exploring that right now.